Uh, Good morning, all. We'll have a short discussion about the maxillary nerve block. And it's like maxillary nerve block and mandibular nerve block. The topic itself is a very big topic. So I've divided the class into the part 1, part 2, and part 3. So you will have a detailed discussion about it. Moving on to the slide. Before going into the any nerve block, one should know this definition. I hope everyone knows this definition. So I'll brush up this. Local anesthesia is defined as loss of sensation in the circumscribed area of the body caused by depression of excitation in nerve endings or inhibition of conduction in the peripheral nerves. So this is a well-known definition of local anesthesia, which is given in the Malamat 5th edition book. And we'll see that what is this maxillary nerve. Maxillary nerve, I hope everyone knows that, is one of the branch of trigeminal nerve. Trigeminal nerve is the fifth cranial nerve and it's the largest of all the cranial nerves. And it's a mixer nerve consists of sensory and the motor nerve. And this is a pictorial representation shows from where the maxillary nerves comes out. So this is a picture which shows that where the maxillary nerves comes out. So this shows that the trigeminal nerve which comes out through the foramen rotundum and gives rise to the maxillary nerve. And this is a pictorial representation of it. Coming into it, this heading, which is called needle gauge. I have added this slide in order to show that there are various sizes of needle gauges. So sometimes you might get a picture-based question in this needle, the size of the needle gauge. Which size, which color of this needle gauge indicates it. So in order to cover that, I have put this slide. So before going into it, gauge refers to the diameter of the lumen of the needle. Smaller the number, greater the diameter. I hope this everyone knows it. There is an increased resistance to the aspiration of blood through the thinner needle compared with that of the larger needle. There is something is called needle deflection, which occurs along the axis of bevel and the breakage must be examined. So smaller the needle, more it deflects. So nothing but deflections come back so that it will deflect back again. So how to avoid it? Sometimes if it deflects, so it will get break. So that should be examined. So what to do to avoid it or to overcome it? Sometimes you will get a question that stating that what is this birotational technique? This is nothing but the operator rotates the needle in back and the forth rotational movement while advancing the needle through the tissues, which results in less deflection, less forces needed for the penetration. As a result of it, we will prevent the breakage of the needle. Just remember there is a technique to prevent the deflection of the needle. The technique is called birotational technique. Coming into the picture, this is a picture which shows us the color and the sizes of the needle. Green color, this is called olive color, which indicates the 14 gauge needle. Amber color, which indicates the 15 gauge needle. Gray color is a 16 gauge needle. Green color is 18. Pink is 20. Purple is 21. Blue is 22. Orange is 23. Red is 25. White is 27. I'm not going to repeat it again. You just take a pic of this slide, and this is the most important slide. You might get a question based on this slide also. Coming into the type of LA injections, there are three types of LA injections. They are field block, nerve block, and local infiltration. We'll see this in one by one. What is this local infiltration? The name itself states that you are going to block the small terminal nerve endings in the area of dental treatment. So small terminal nerve endings. Whenever you come across the term, you are anesthetizing the small terminal nerve endings called as local infiltration. Coming to the field block, in a field block, local anesthetic solution is deposited near the larger terminal nerve ending. So that is the difference between the local infiltrations and the field block. So this larger terminal nerve ending is the field block and the small terminal branches is the local infiltration. So it is infiltrated around the border of surgical field, leaving the operative area undisturbed. Maxillary injections administered above the apex of the tooth to be treated or properly referred to as field block, not a local infiltration. Just note down this words. Nerve block. In nerve block, anesthetic is injected directly adjacent to the nerve supplying the surgical field. Example of it is proorbital, supratrochlear, infraorbital, mental nerve block can provide adequate anesthesia in a procedures on a part of the face. Nerve blocks are used for pain and management. Often a group of nerves are called as plexus or a ganglion. So that causes a pain to the specific organ or a body region can be blocked with injections of medication into the specific area of body. The injection of this nerve numbing system is called as nerve block. So now we have seen the three types. It's called as local infiltration, field block, and then nerve block. Local infiltration is just nothing but anesthetizing the small terminal nerve endings. Whereas field block is larger terminal nerve ending. Nerve block is injecting directly into the adjacent nerve supplying field. Coming to the factors that affecting the selection of the techniques to be used. They are area to be anesthetized, extent of surgical procedure, duration of anesthesia, age of the patient, hemostasis, and the presence of infection. First one is area to be anesthetized. Depending upon the type of the bone density, the maxilla and then mandible, anterior mandibular region, they are mainly formed of cancellous bone and of the thin cortical bone above. So if you do an infiltration, you can able to achieve the perfect anesthesia in this region. So that is why I put this, I put the sentence which is stating that maxillary and the anterior mandibular region are mainly formed of cancellous bone with a thin cortical layer above, allowing infiltration anesthesia or a field block anesthesia reach the nerve filaments inside the cancellous bone. Coming to the extent of a surgical procedure, in a multiple extraction, if you are going to plan a multiple extraction, there is no point in giving on a field block or a local infiltration. So it's always better to give a nerve block anesthesia. So remind that. So depending upon that condition, you have to choose the nerve blocks. Allow the anesthesia of entire operative area, prevent a multiple needle puncture. So in order to prevent that multiple needle puncture, for example, if you are going to give a local infiltration, you are going to anesthetize only a particular tooth. Whereas in cases of the nerve block, you can block the entire area. So multiple penetration can be prevented. Duration of anesthesia. So the nerve block anesthesia produces a prolonged period of anesthesia. So that should be reminded. Age of the patient. Older the individual, have a denser the bone. So denser the bone, it will be very difficult for infiltration. Coming to the hemostasis, when required for the procedure, infiltration anesthesia is recommended to allow the vasoconstrictor present with the local anesthetic to act directly on the blood vessels and reduce the bleeding. Coming to the last is the factor is presence of infection. Infiltration anesthesia should be avoided in order to prevent the infection into spread into the adjacent site. So that keep in that mind. Coming to the hero of this topic is maxillary injection technique. What are they? They are intraoral and extraoral nerve blocks. Intraoral are anterior superior alveolar nerve block, middle superior alveolar nerve block, posterior superior alveolar nerve block, greater palatine, mesopalatine, and maxillary nerve block. Coming to the extraoral techniques, it includes infraorbital nerve block and the maxillary nerve block. First topic is PSA, which is nothing but posterior superior alveolar nerve block. It is also called as tuberosity or a zygomatic nerve block. The nerve that get anesthetized is the posterior superior alveolar nerve. Area that get anesthetized will be the maxillary molar, with the exception of the mesiobuccal root of the first molar. Just remind, when you give a PSA nerve block, all the maxillary molars will get numb, except the mesiobuccal root of the first molar. The buccal alveolar process of the maxillary molars, including the overlying structures which includes periosteum, connective tissue, and the mucous membranes that also will get anesthetized. Success rate will be more than 95% and the positive aspiration will be 3.1%. Coming into the anatomical landmarks, which includes mucobuccal fold and its concavity, zygomatic process of maxilla, infratemporal surface of maxilla, anterior border and the coronary process of ramus of the mandible and the tuberosity of the maxilla. Indication for the operative procedure of the molar teeth. Whenever you are going to do some procedures in the molar teeth, you have to give a PSA nerve block. The injection must be combined with the palatal injection. Why? It should be combined with the palatal injection? Because when you give a PSA nerve block or MSC nerve block or anterior superior alveolar nerve block, these will anesthetize the region which is present in the buccal aspect, not in the palatal aspect. When you are going to do the procedures in the maxillary teeth, you have to anesthetize both the buccal and the palatal to do the pain-free procedure. So that along with that PSA, you have to give the palatal injection always if you are going to do the procedure. What is the contraindication? There is a risk of hemorrhage in a patient who is having a hemophilic condition, so you should not give this nerve block. Coming into the needle pathway during incision, if it penetrates the mucosa, areolar tissue, possibly the buccal pad of fat, so, and it penetrates the posterior fibers of the buccinata muscle. What are the approximated structures when the needle is in position? They are posterior to the posterior surface of maxilla, anterior and lateral to the anterior margin of external pterygoid muscle, anterior to the pterygoid venous plexus, and the needle will be in proximity to the posterior superior alveolar canal through which the posterior superior alveolar artery, vein, and the nerve pass. Indication for operative procedures of molar teeth and supporting structures, the injection must be combined with the palatal injection. So remind this indication, it has to be combined with the palatal injections. So coming into the area of insertion, it is like height of mucobuccal fold of maxillary second molar teeth. Remind the area of injection will be the height of mucobuccal fold of maxillary molar teeth. Procedures: orient the bevel towards the bone. Ask the patient to open the mouth partially. Pull the mandible towards the side of injection. Insert the needle slowly into the mucobuccal fold of second molar teeth. Advance the needle slowly in upward, inward, backward. These three words is most important whenever you are going to give a PSA nerve block. Upward, inward, backward. You have to advance the needle. This will Jorgensen and Hayden advocate the bend needle technique. Just remember the name of the author. They are Jorgensen, Hayden, who advocated the bend needle technique. Opinion in that it would be more accurate considering all the dimensional variations. So the needle is inserted distally, superiorly at 45 degree to the mesiodistal. This is a pictorial representation. You can able to correlate the sentence and the picture. You have to insert the needle distally and superiorly at 45 degree angulation, mesiodistal and the buccolingual plane at the height of mucobuccal fold of the maxillary second molar teeth. Remember, the depth of insertion should be 16 mm and slowly you have to do an aspiration in a two plane. So just remember, whenever you are going to deal with the PSA nerve block, remember the two terms. They are called as like depth of penetration. It should be at the two plane, and then the angle, you should orient the needle to 45-degree angulation. And after doing an aspiration at the two plane, you have to slowly deposit the 0.9 to 1.8 ml of solution. Signs and symptoms. There are two types. It's called objective and subjective. Subjective is that patient will tell you. So sometimes the patient will tell you that they are having a numbness, like they are having like a swelling in that region, or they are having like loss of sensation in that region. Sometimes the patient will complain you like that. That is called a subjective symptoms. What is the objective? Objective is nothing but if you are going to elicit. So if you are going to prick the gingiva using a probe and you are asking the patient whether you are having anything of pain, so you have to compare it with the normal site and you have to ask the patient whether you are having any pain or not. That is called objective. You are eliciting the symptom. Whereas if the patient tells you the symptom, that is called subjective. So remember, the PSA will not have this subjective symptom. What are the advantages and the disadvantages? Advantages are atraumatic, high success rate, minimum number of injection and the volume of local anesthetic solution administered, Disadvantage or hematoma, no body landmark. Second injection is needed because like it will not anesthetize the, as I told, mesiobuccal root of the maxillary first molar. So that is one of the big disadvantage of using the PSA nerve block. There we have to require another MSA nerve block to block that root alone. This a pictorial representation shows that where it will anesthetize. So that it shows that except the mesiobuccal root of the maxillary first molar, you will anesthetize all other three molars and the periosteums in that region and the buccal mucosa covering over that region. What are the complications? The most important complication is hematoma. What is this hematoma? Because so in order to how to avoid this, I will also tell that. So in order to avoid this hematoma, we are asking the patient to close the mouth, the half closed mouth position for PSA. Half closed mouth position, while you insert the needle in that position, there are a lot of chances for you to prevent the entering into the pterygoid venous plexus. Because when you have opened the mouth, that pterygoid venous plexus will go in between the lateral pterygoid, medial pterygoid muscles. So you will not have any of chances to penetrate into the plexus. The complication, the most important is, as I told, is hematoma. Hematoma because of penetrating into the pterygoid venous plexus. If you see the hematoma, so the hematoma will develop within a second as soon as it enter the needle into the pterygoid plexus. If you see the hematoma, the best way to treat an hematoma is caused by the PSA nerve block or any other thing. Just give an extraoral compression, a tight compression using a dynaplast. So I hope you people knows that what is a dynaplast, or else just give me a tight compression extraorally. When you give the compression, it is the only option you will reduce the hematoma. So that is the sentence states that bleeding continues until the pressure of extravascular blood equals to the intravascular blood. So coming into the summary of the PSA is also called as reciprocity nerve block, as I told that. So this is the other name of the PSA. It's a reciprocity or zygomatic nerve block. And the target area are posterior, superior, medial to the posterior border of the maxilla. Area anesthetized will be the maxillary second molar, third molar, and the distal buccal root of the first molar. Nerve anesthetized is the PSA. Landmark will be the mucobuccal fold, maxillary tuberosity, and zygomatic process of maxilla. Aspiration is 3.1%, and the signs and symptoms, the patient will not have the subjective symptoms, only the objective symptoms will be there. So just remember, at least the most important point when you are going to read about the PSA. Other name, depth of penetration, and the aspiration, in what field and how many times. So what will be the symptoms and what is the landmark where it get anesthetized. Coming into the MSA. MSA is for middle superior alveolar nerve block. So it's present only in 28% of the population. So this is what the author told us. So it's called, there was a study was done by the Roshan and its associate who found that only 28% of population has this MSA nerve, middle superior alveolar nerve. So it originates approximately 10 mm posterior to the infraorbital foramen. MSA will anesthetize the mesiobuccal aspect of maxillary first molar, both premolars, PDL, buccal bone, periosteum, along with the soft tissue latent to this area. The posterior aspiration is less than 3%. The technique is 27 gauge short or long needle is used. 1 ml of the anesthetic solution should be slowly introduced after the careful aspiration. Area of insertion is height of mucobuccal fold above the maxillary second premolar. Just remember, above the maxillary second premolar. The needle tip should approximate the apex of the tooth, which is usually requires a penetration of about 5 mm. Target area will be the maxillary bone above the apex of the maxillary second premolar. Landmark, mucobuccal fold above the maxillary second premolar. So this is a picture which shows that the region where the MSA nerve will anesthetize. So when you give the MSA nerve block, the mostly the anatomical area is mucobuccal fold above the maxillary second premolar. The target area, as I told, it's above the apex of maxillary second premolar. So the area will get anesthetized will be the mesiobuccal aspect of maxillary first molar, Premolars, both premolars, the periodontal ligament, buccal bone, periosteum, along the soft tissue lateral to this area. Coming into the summary, as I told, it's MSA. Target area is above the apex of maxillary premolar. Area anesthetized will be the maxillary premolar, both the premolars, first and second premolar, and the mesiobuccal root of the maxillary first molar. Nerve anesthetized is maxillary MSA along with its terminal branches. Landmark is the mucobuccal fold of the maxillary second premolar. Aspiration is post aspiration will get in less than 3% chances. Signs and symptoms, both subjective and objective signs and symptoms will be there. Complications, hematoma rarely occurs compared to that of PSA. Coming into the ASA, which is called anterior superior alveolar nerve block. It originates approximately 5 to 8 mm posterior to the infraorbital foramen, whereas MSA will originate 10 mm posterior to the infraorbital foramen. So just remember these two terms. It is also called as infraorbital nerve block. It now anesthetized will be ASA, MSA, and infraorbital nerve. Area anesthetized will be the periodontal ligament, alveolar bone, periosteum, buccal soft tissue, and the teeth from canine to the midhead. Posterior aspiration is 0.7% and alternate if not infraalveolar nerve block, you can either give a supraperiosteal or PDL or maxillary nerve blocks. So the needle, the depth will be about 16 mm for an average size adult with varying depth proportion to the size of the patient and the bony structure of the cheek. Area of incision is height of the mucobuccal fold directly over the first premolar. So that is the difference between the MSA, PSA and PSA. MSA will be the second premolar and then PSA will be the second molar and ASA will be the first premolar. What is the target area? Target area will be the infraorbital foramen below the infraorbital nerve. So that there are two areas, extraoral and intraoral. Extraorally with the non-dominating and you have to palpate the infraorbital foramen. Intraorally, you have to insert the needle along the mucobuccal fold of maxillary first premolar. Landmarks, mucobuccal fold, as I told, extraorally you have to palpate the infraorbital notch, infraorbital foramen and orient the pupil towards the bone. So this is a picture which shows that in using a non-dominant and you have to palpate the infraorbital foramen using a dominant and insert the needle intraorally towards the bone along the first premolar region. The needle depth will be about 16 mm as I told in the previous slide. What is this under failure of anesthesia? So whenever the needle contacts the bone of lower border of infraorbital foramen, anesthesia develops in a desired soft tissue area alone, not in the hard tissues. So that is why a failed ASA is supraperiosteal injection should be used over the first premolar. Needle deviation, medial or lateral to the infraorbital foramen. Complications will be a hematoma may develop across the lower eyelid around the infraorbital foramen. There are two approaches. So what are the approaches can be used for the infraorbital nerve block, which includes bicuspid and the central incisor approach. What is this bicuspid approach? The name itself states that you are going to insert the needle along the premolar. Bicuspid, the needle is inserted into the mucosa, the areolar tissue, using the maxillary bicuspid as a guide, and the needle should pass beneath and lateral to the external maxillary artery and anterior facial vein. Coming to the central incisor approach, this is a picture which shows that where you have to direct the syringe. The syringe has to be directed in the line passing oblique from the mesio-incisor angle of the central incisor. So with this picture, you can able to appreciate this is the mesio-incisor angle of the central incisor. You have to direct the syringe in the line obliquely from the mesio-incisor angle of central incisor to the distal cervical angle to the apical region of the root of the canine. From the mesio-incisor distal cervical to the apical region of root of canine, you have to direct the syringe. The needle is inserted at about 5 mm out in the mucobuccal fold above the tip of the root of the canine. The needle is pushed till it contacts the boundary of the foramen. This is called as central incisor approach. That is called as bicuspid approach. Just remember at least that there are two approaches to the infraorbital nerve block. Coming to the summary of infraorbital nerve block, it is like a target area is a foramen extraoral landmark. Intraorally, the mucobuccal fold of the maxillary first premolar. And the area anesthetized will be the maxillary canine, major incisors, and central incisor. The nerve anesthetized is ASA, orbital. And the landmarks, as I told, is either extra or internal landmarks. In signs and symptoms, both are subjective and objective signs and symptoms. And coming into this slide, which shows the overall summary of what we have seen still now. So we have seen about the supraperiosteal, PSA, MSA, nerve blocks, and ASA nerve blocks. So just take a pic of this slide so that you can able to remember what I'm dealing with that. And coming into the other names, sometimes you might get a questions based on the other names also. They are called supraperiosteal nerve. It's also called as local infiltrations or a paraperiosteal injection. PSA is also called as tuberosity block or a zygomatic block. ASA is also called as intraorbital nerve block. Thank you.